Welcome to Vision 2020 USA's Spotlight Series. Today's topic, TECS, Technology-Based Eye Care Services, featuring Dr. April Ma of the Atlanta VA and the Emory Eye Center at Emory University. The Spotlight Series is hosted by Dr. Rajiv Ramchandran of the Flom Eye Institute at the University of Rochester and Dr. Dean Van Asdale of the Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
So just for folks on the call and those joining, this is Dr. April Ma at the Emory Eye Center and VA, and is leading an initiative called TECS, which is the Technological Application of Eye Care Services. And so bringing technology into how we deliver eye care, and she's going to talk about eye care from anywhere, so from everywhere. So go ahead, April, and take it away.
All right. All right. Well, thanks everybody for inviting me. I'm very excited to share about what we have been doing at the Veterans Health Administration, probably now almost over the last 9 to 10 years. And I'm also, this is a great group to be speaking with because I'm very passionate about eye care access and healthcare disparities. And I think that's really what's driven all of this work that I've been spending my career on. So just going to give you guys a brief introduction about eye care delivery models in the VA and how the telehealth care delivery model that we've been utilizing for a few years now has been used and impacts the VA system. And then what I'm really excited about is that I think we're finally getting enough data to show that it helps to promote health equity. So here's the objectives. We're going to talk a little bit about VA organizational structure, just to give you a context, then talk about our telehealth infrastructure, which is very extensive, and then our work that we've been doing, technology-based eye care services, and then our new work, National Subspecialty Ophthalmology Network, and how I feel like this helps to contribute to health equity. And looking forward to a lot of discussion and input from this group about, what we could do better, other suggestions, how as we move forward in our work. So I want to start by telling you about this true story. Mr. C came to see me. This is many years ago now. I've been in the VA. This is my 17th year, and so he's 78 years old. He's African American. He lives in Blairsville, Georgia. I physically live in Atlanta, and Blairsville's a small rural town in the mountains, about 2 hours away from the main Atlanta VA. Last eye exam. Oh, doc, I don't know. Maybe 5 years ago, maybe. I don't know if I've ever had one. And then the chief complaint, this is very common. I can't see. Can you give me some glasses? So just as a side note, the VA does pay for free glasses for veterans. That is the only thing they care about. Free glasses. And so no pertinent eye history, just he has diabetes. But then when you do his exam, this is what we see. Very, very poor vision, uncorrected with best, cannot be correctable even with with manifest refraction, very high APD, very high eye pressures, positive APD, and very cupped nerves. And I think the sad thing about this is that I saw these patients all the time. And it just really frustrated me because I was like, if only we were able to see you sooner, you wouldn't be coming to me and me having to tell you that you were now legally blind from glaucoma or that you had really severe glaucoma. Like if I could only catch you earlier, what could I have done to save your vision, right? And so that's kind of what was really the impetus for all of the work that I have been doing at the VA. And the really scary thing to me was that Mr. C is not a atypical veteran. He's a typical veteran. The average age of veterans using VA is greater than 55 years old. Higher rate of diabetes, possibly due to chemical exposure during warfare time, like Agent Orange, for example. The VA generally has a higher rate of underrepresented minorities, and they're more likely to live in rural or highly rural areas because they're either retired, they prefer the peace and quiet of the country. Some of them are in, lower socioeconomic status that access the VA for healthcare, and therefore they tend to live in the rural areas because it's cheaper to live in the rural area than the urban area a lot of times. So this is how we're organized, and this is a very gross, model. It's certainly not very detailed, but I kind of think of it as at the national level, we have program offices. So we have the ophthalmology program office, we have the Office of Connected Care, for example, which is the telehealth office. And at the regional level, we have Veterans Integrated Service Networks, or VISNs. And that is a collection of hospitals that's a collection of hospitals that belong to a certain collection of states. So I used to work for Vision 7. I now work for Vision 23. And so as part of the regional Vision, then there are the facility levels. So for example, in Vision 7, which is a Southeast network, we have Atlanta as a VA facility, Charleston as a VA facility, Central Alabama as a VA facility. This is not an exhaustive list. There's about 7 or 8 facilities under Vision 7. And then each facility has CBOCs, or community-based outpatient clinics. Think of those as primary care outreach centers. They're scattered all around the VA facility, and they primarily produce primary care. So the example for Atlanta, again, not an exhaustive list, but we have Blairsville, we have Rome, we have Newnan, we have Fort McPherson, we have North Arcadia, we have Covington, etc. And so because of the way the VA is structured, we have lots of issues. We have some problems like large catchment areas, many rural areas, very high demand and growth for eye care. We are the 3rd highest in demand service across VA, behind mental health and primary care. And then, so as a consequence, in a resource constrained environment, we have, potentially long wait times, far drive times if you live in Blairsville, for example, and therefore that leads to poor access. And I think that poor access leads to healthcare disparities. There's a lot of reasons that, in addition to poor access for healthcare disparities, but I think that distance to care is one of them. And so the VA has multiple solutions in the toolbox. It's a very complex problem, obviously, but some basic ideas that we've been doing is building more clinics, right? Building clinics closer to the patient, Community Care and Mission Act, where the VA acts like an insurance company. So then we say to the veteran, oh, well, you can't get care at an Atlanta main VA, but you could go to Covington Ophthalmology Surgical Group and we'll pay for it. We'll act like an insurance company, we'll pay for that. And then we have telehealth. And so traditional eye care delivery without telehealth looks something like this. Mr. C has blurry vision. He goes to his VA primary care doctor. His VA primary care doctor goes, well, I don't know what's wrong with you, so let me send you to. And then he has 3 options, the primary care doctor: community care optometry, VA optometry, and VA ophthalmology. And at different facilities, it could be any one of these so-called buckets, right? Just depending on what's available at that place. Now, Mr. C gets diagnosed, like we just said, with severe glaucoma. Let's say that happens in community care optometry or VA optometry. Now, where does the patient go? Now that bucket of provider has to send either to community care ophthalmology, VA subspecialty eye clinic, or VA ophthalmology, and all of these people could be kind of far away depending on where Mr. C lives, right? And then to further complicate this, we might even need to send it to a subspecialist. So maybe this ends up going to comprehensive ophthalmology, and the comprehensive ophthalmologist is like, I can't take care of this, and sends it to now the glaucoma specialist. That glaucoma specialist is even further away from the patient potentially, especially if you're rural. Bottom line is, I don't know about you, but this gives me a headache. Like, patients going everywhere, all sorts of different places. All of the care is very, very siloed. If you're going outside the VA and then coming back into the VA, there's no EMR integration. It's very inefficient. My poor veteran patient who's 78 years old and can't drive now, he can't navigate this. He's going to get lost to follow-up, and the consequence is dire. He's going to lose vision. So my proposal was that telehealth helps us to work smarter. So if we consider all our patients on a spectrum of a pyramid, a lot of patients are just going to need basic care. They're just going to need screening and eyeglasses, right? And then some of them are going to need more things. And then the even smaller percentage, but important percentage, are going to need subspecialty care. So the idea is that so the initial idea was that we're going to use telemedicine to take care of this basic level, help us sort out what do the patients need, and not necessarily see all of these guys at, face to face. So that's how we bore out technology-based eye care services. So this is how this model works. At the primary care clinics that are scattered across the VA system, we station a ophthalmology technician, and they do the same workup that you would get in person: history, vision, pressure, pupils, imaging protocol, and then we prescribe glasses, or at least measure for glasses, prescribe them, order them, and make them and send them to the patient's house. And we put all the information into the chart. This all happens in 120 square feet. And these are some pictures of the Austell CBOC, courtesy of Aaron Gerals, who works there. And you can see that there's no traditional slit lamp or anything, but we have all the necessary components to do a really good quality exam. And so one of the first things I wondered about when we started this type of program was, can we use pictures to diagnose disease? Like a lot of us look at something, see the disease, and take a picture of it, right? What about doing it the other way around? And I was really pleasantly surprised to see that there's all this literature that shows that it's actually pretty good. And in fact, for certain conditions like diabetic retinopathy, it's actually a little bit better looking at a photo than looking, in person. Now, it's probably equivalent if we're talking about, you know, NVD, PDR, DME. But if we're just talking about looking for diabetic retinopathy, period, like even mild diabetic retinopathy, sometimes photos were better. And so in March 3rd in 2015, TECS has its birthday. TECS was born. We had 3 rural sites funded by the VA Office of Rural Health. That was Blairsville, Rome, and Noonan. And I want you all to note how far away that is from the main Atlanta VA. At the time when we started this in 2015, basically that was the only place veterans could go to get care. If they wanted glasses, if they needed more than glasses, all of us were right here. And they would have to drive this far. And Mission Act did not exist. So, and then after the start of the pilot, it worked so well that the main Atlanta VA actually spent money to set up 2 additional sites that were a little bit more rural. That were a little bit more urban as opposed to rural focus. And so we had 5 sites going by about 2017. The data that we gathered showed high impact for all veterans served, not just the rural veterans, such that we were fortunate enough that Office of Rural Health turned us into an enterprise-wide initiative, which means that we would get funding yearly to set up multiple sets of TECS across the VA. And I'm proud to say that in fiscal year 2024, 9 years or 7 years after the EWI started and 9 years after we started our initial pilot, we are now seeing 52,000 veterans across the entire VA system. And we were able to do quite a bit of quality improvement and quality assurance with my informatics team to publish a lot of literature on TECS and to ensure that we were really doing what I was hoping we would be able to do. And so you see some of the findings here. So patients were incredibly happy. We were doing a lot better in terms of no-show rate, and we were reducing the time of the appointment length, the cycle time, both for the physician and the patient, compared to an in-person visit in the Atlanta VA clinic. And then we thought to ourselves, how could we improve our diagnostic accuracy? What if we added OCT to all of these patients? And so we ran a larger trial in a more of a research setting where we basically ran everybody through the TECS protocol. Everybody got OCT, regardless of whether you needed it or not. And then you saw the face-to-face exam. And this is kind of what we found. So we actually found that the OCT nerve did not improve diagnostic accuracy. This was more geared towards glaucoma detection because I think, as we all know, glaucoma is, you could look at the same patient and treat them a couple of different ways and sort of both be within standard of care. So we looked at glaucoma specifically, and we found that OCTing everybody, not surprisingly, did not improve diagnostic accuracy. In fact, it made it worse. So we decided not to add OCT to the initial screening protocol. But then the other exciting thing is that the field was innovating on this model, which I was just so excited about and so proud of the field for doing this. It takes a village to do this, and we have a great village in the VA to do this. So mobile eye care stations started popping up, and so we now have 2 of these where we just put the same equipment and the tech, and we just drive it, and so we could reach even more patients that were more rural, that live in communities where it's even the primary care doctors travel to them. And then this is the most impactful data that I'm super excited to share with you. This is recently published in ophthalmology, and this is the national TECS data. And what we looked at was a whole bunch of different measures about implementation, sustainability, and then logistic regression models for eye disease risks. And this is kind of what we saw. So from the implementation and sustainability standpoint, it's looking pretty good. It takes a really long time to set up the program, 1.3 years on average. This is the VA, we're on government time. But we do get a good activation success rate. So from the time they start to the time they start seeing patients, it's 91.8%. And then once the seed money expires, for those that are, in the window of having spent the seed money, which is 3 years from Office of Rural Health, 72.2% continue to sustain the program. So this is really great because I think this means that people like the tool and it's integrated into the way they're going to deliver eye care in the future. And this is where I'm really, really proud of the work we've done and really am excited about the future work we've done, which is what we found was that if you see us for the first time to get glasses, because remember, all they care about are their glasses, right? What we find is that if you're rural or highly rural, you're much more likely to be diagnosed with what we call vision threatening disease, number one. And number two, you're much more likely to have a high burden of disease. So I'm not just going to get diagnosed with as a glaucoma suspect. I'm going to get diagnosed with moderate glaucoma or severe glaucoma, like Mr. C in the beginning. We talked about him because I'm rural. I'm also going to get diagnosed with glaucoma and macular degeneration, or I'm also going to get diagnosed with glaucoma and diabetic retinopathy at a much higher rate than if I were urban. And this was really interesting because the rurality was the greatest predictor for advanced disease and greater disease burden, even more than social vulnerability. So we even looked at social vulnerability indices and things like that, and rurality was the number one reason. And so, to me, that sort of makes sense. If you don't have access and you're not getting regularly screened, maybe even for your diabetic retinopathy, you're going to get diagnosed at a later point for disease, right? But not a lot of papers are able to show this. And so it's interesting that our paper did show this. And it's just another, comment about what do we need in the future, specifically with respect to VA. And so, the VA, the ophthalmology workforce studies that don't necessarily include VA, so sort of all over the United States, show that we are projected to be the third worst among all specialties in terms of workforce adequacy by 2035, which is not that long away. And that the rural workforce shortage is 3 times deficient compared to urban areas. And these are a couple of maps that I think really just tell the story. As the American population ages and as our veteran population ages, more people are going to need these subspecialists, but will have even more difficulty accessing that care. Because if you live in here or you live here, where are you going? You're driving miles and miles and miles to get to them. And I think that what that means is that you're not going to get it. I think you're just not going to be able to get there. And so for us from the VA system, we already had an infrastructure of, eye screening with technicians, right? So now we're leveraging now we've developed the National Subspecialty Ophthalmology Network, NSIN, and it started this year. And it's really the natural next step or evolution of the TECS model. And our goal is to deliver retina, glaucoma, and neuro-ophthalmology subspecialty care to these veterans using all different models of care delivery, asynchronous, synchronous, and hybrid telehealth. And so we're only going to exclude patients that can't be properly cared for by our model. So we don't have good slit lamp access. We know that. We're looking to places like India, to learn about what they're doing to kind of help improve this. But if you have a corneal ulcer, if you have peripheral retina disease, if you need procedural eye care, obviously you're going to be excluded because this is currently telehealth based. But basically the patient is going to go to a pre-existing advanced tech site along in the rural area or potentially an eye clinic that does have, testing equipment. And then we're going to get testing followed by a protocol. Subspecialist going to review the test, use video or phone, talk to the patient and provide care directly. But that video chat I envision, will be far more impactful because we will have all the other information that we need to properly take care of the patient, including vision, refraction, photos, OCT, visual fields, MRI scans, etc. So we're covering 3 subspecialists. We have 2 pathways for care. This is kind of the overview of the process. The eye doctor that's taking care of the veteran decides whether they want to e-consult just as an opinion for support, or they want to schedule the patient to be, transfer that care to the subspecialist, and then we will work with them from there. And this is a hub spoke model, so it's going to be centralized. And in my new VISN, which is VISN 23, the rural Midwest, we are the most rural VISN in the country. And so we're going to centralize that care and deliver it to the whole country through our EMR and our network of telehealth. And so here's our proposed quality framework. drive time save, wait time for appointment, number of encounters, number of, when we say unique, just the number of patients, specific patients seen. Each patient may have more than 1 or 2 encounters. And then quality specific metrics. Are we reporting our results? Are the patients satisfied? Is our image quality good? Is our OCT quality good? Is our visual field quality on par with the in-person clinics? So we've started doing some of this. Retina is our most mature service. And so we're serving 13 VA healthcare systems. And you can see the number of telemacula clinics we did in fiscal year 24, which is the number of encounters we did seeing patients for retina disease, 592, and then 125 e-consults across the enterprise. And so, you've seen this already. I said we're using telemedicine TECS to do basic care, and now we're going to use telemedicine ensign to do the intermediate and more advanced care that's non-procedural, and then save the advanced, save the time of the subspecialist for complex disease. Just try to get more efficient. Meet the patient where they are, take care of them, know what they need before you send them. So ideally, my goal in the next 5 to 6 years or 10 years, depending on how long it takes, I want patients who need eye care to go to a traditional eye clinic, but I want that traditional eye clinic to have multiple options. So they can send them to PCP sites, send them to our hub, re-enter care at a later time frame if they're normal, and then for us to care for them in this infrastructure, and then sending patients back when they need in-person care, surgery, anything of that nature, and then supporting the traditional eye care clinic with in-person deployment. So if you're a hub, maybe you travel to do the injections that you might be managing through telemacula clinic once a month. You go to a traditional eye clinic place, you get the patient there, and you take care of them, because access at the traditional eye clinic space is also difficult. So I just, want to close out this talk by, again, going back to this concept of healthcare equity and healthcare disparity and how this works. And this is my dream, my new dream. One veteran seen in Kalispell, Montana at the TECS telehealth site, one veteran seen in Dublin, Georgia at a brick and mortar optometry clinic with disc edema. They both need neuro-ophthalmology. Right now, where do they go? They go to community. Kalispell veteran goes to Salt Lake City. That's 10 hours drive time away. That's a flight. Or Dublin goes to 2 hours. We've actually had this happen. The Dublin veteran said to us flat out, "I'm not going." And so we had to find some other way to take care of him. If we were to have Ensign built out in the future for neuro-ophthalmology, we could have both of these veterans go in through a consult. We could do a video-based call. We could render that care within a week or two. And we could really provide, in my mind, what is the epitome of health equity for these veterans. We're going to save their sight. We're going to get that care to them. And we're doing what is our charge, which is to take care of those who served. So in summary, I truly believe that ocular telehealth programs, especially if deployed system-wide, have the ability to reduce healthcare disparities and improve healthcare equity. I'm really, really lucky that I work in the VA where this is heavily facilitated, but I think that as a greater whole, we need to be looking at doing this in all our systems, big or small. Maybe the federal health, federally qualified healthcare systems, maybe in a system like Wellstar or Kaiser, to really think about how are we going to address our workforce disparities and how are we going to meet our patients where they are. And that's it.
That's wonderful. Thank you so much, April, for that great uh, journey through your process and through all the development that you've done. It's just amazing that, it's only been almost not even 10 years yet, and you've created so much. So you've had a lot of success in this area. What do you think are your biggest challenges, even early on, in sort of setting this up? Because, you surmounted probably a lot of obstacles and hurdles to kind of get it going. What did you face early on, especially?
I think that with anything new, we were really trying to change the model of care within the VA. So I think that buy-in on from all aspects was pretty challenging in the beginning. When we start first, and I also, think that I didn't do a very good job talking about how this is a collaborative effort, that it requires the entire eye care team, from the technicians to the providers, both on the optometry side and the ophthalmology side. So that was a pretty significant barrier, because when you launch something like this, one of the first things, so some people think it's fantastic, right? Right away, they're on board with the vision. The others, rightfully so, are thinking, oh, you're trying to replace me, and I think that we've had to do a lot of education and a lot of, buy-in on that. But I'm really happy to report that, I think we're bought in now. We're beyond that barrier, but that was a huge barrier that we definitely needed to address. Just the fear of change, and address those concerns.
That's true. It's very, very daunting when somebody thinks that somebody else is coming to take their job. So I think that's a lot of relationship building that you've had to do.
Right.
And another question comes from Dr. Mitch Brinks.
Okay.
He's asking about how are the patients scheduled? Are they within their normally primary care visits, or is it a separate visit? How does that work?
Yeah. So this is a really good question. I'm so glad you asked. I will just want to say that scheduling keeps me up at night, because if you have poor scheduling, you have poor utilization, even if you have space, right? So the way it works is that we tried with the primary care doctors to do a walk-in clinic. That's, some walk-ins, but that really didn't work for us. And also the veterans realize they're going to get dilated, because it's an eye exam, right? So I'm going to dilate you to get high quality photos. And so in the end, what we did is we schedule it as a separate appointment, but because it's located in their primary care clinic, we certainly can say, hey, Mr. Smith, you've got an appointment with your primary care doctor today, or in 1 week. How about if we also do your eye exam at the same time for diabetes? Don't you want free glasses? And, if they're prepared and they're able to do it, usually the answer is yes. So the scheduling occurs locally. We try hub-based scheduling as well. That doesn't work as well, because really, if you want patients to have access, you need to lower the activation energy. So you need that patient to be able to show up at the front desk and be like, I want an eye exam, and get scheduled right then and there. The other thing that's been very, very helpful is education on the primary care, the physicians' parts. Um, they love this program because they don't know anything about eyes, and they don't want to know anything about eyes. For them, this is a slap the easy button. So a patient comes in and says, I have this eye problem, when they, are having their routine physical, and the doctor goes, oh, you know what? Go next door. There's the eye clinic right there. And then the patient can make an appointment and an immediate referral. So that's very, very helpful as well.
And do you have like walk-in clinics, or is it all scheduled?
We will take a walk-in if for some reason, the technician is the only technician there, so they're doing everything. So it's hard to take a walk-in. They're usually fully booked out, but if somebody doesn't show up and it's, at the right time, they certainly will try to take a walk-in if they can.
Mhm.
So the answer is yes, we'll definitely take a walk-in. The question is whether there's availability or not. But
And
usually patients are pretty happy about coming back if they can't be worked in for a walk-in, right? Because it's close to them. They're not driving 2 hours to the eye clinic. They're, you know, driving 10 minutes to their primary care doctor.
that's true. And do you know what the no-show rate is at your clinics?
It was, according to the data when we looked at it for TECS, it was lower than uh, the main eye clinic. I haven't looked at that data recently, also because it's become progressively more difficult to look at no-show, partly because sometimes patients are actually going out to community,
Mhm.
and so they may not show up because we have this third variable. In 2015, when we started the program, we did not have the third variable of community care. Now we have the third variable of community care, which makes data collection a little bit more difficult. But in 2015, when we started it, the rural areas, the no-show rate in the Atlanta VA eye clinic, just for people showing up to clinic, was the no-show rate's pretty high. It's like 15% maybe, and it was about 5% in the TECS clinics. So it was better.
And then another question from Dr. Brinks is about medical legal issues.
Mhm.
Is that something that you have to deal with in the VA?
So that's a really good question. I mean, yes, if we have medical legal concerns, but that is one of the reasons that what we're doing is, while I think it would work outside the VA, it's much more difficult to do. So because we're a federal system, we have federal supremacy. So I only need one license in any state as long as I'm practicing within the VA system to care for all these veterans across all these states. So I, with my Georgia license, can take care of a patient via TECS in central Alabama, in Minneapolis, in Kalispell, Montana, without worrying about the fact that I have a Georgia license and not a Montana license, not a Minnesota license, et cetera. So that's very, very helpful, for us, because that is the logistics of just something like that is very difficult outside the VA.
Any other questions or comments? You can raise your hand too and ask. You're a small enough group here.
This is Dean. I've got a quick question. Sorry if there's a lot of noise in the background.
No worries.
You talked a little bit about sort of the integration of vision care sort of into primary care services where you have all the services sort of in one location.
Yeah.
And I think things like federally qualified health centers are really well positioned to do that. Could you describe a little bit about how you think about using federally qualified health centers to sort of facilitate care more? And is that something people should be looking at? And should we be trying to get more providers into federally qualified health centers to help coordinate that care?
Yeah, I mean, I think, so I think that what I would do is sort of think of it like this. And I mean, then you get into the whole concept of how do you get paid for this, right? Because like in the VA, it's hard to, again, these are challenges that are very real for outside VA systems. So it costs money to set up equipment like that. It costs money to have a technician there. You have to pay the doctors, time. If you can't bill for that outside and recoup some of that cost, it's harder to launch. But if we take the cost aspect out of it for just a second and we want to focus on just the concept of how you do it, a lot of federally qualified health centers, I think, now have rooms in which they might be doing diabetic teleretinal screening, right? Like that. And that was the infrastructure upon which TECS was built. It was actually built on, the VA's had a diabetic teleretinal screening program for years, like since 2006 or something like that. So every primary care clinic has like a designated little telehealth room where there was a fundus camera, and they might have a camera for derm and a telehealth cart for mental health and stuff like that. And so we can leverage that space, right, and that infrastructure to do the same thing. So I think in a federally qualified health center, I think it would make sense. Like I work in Grady, which I believe is would count as a federally qualified health center, our county hospital, and we have diabetic teleretinal screening at all these CBOCs. Right now, we farm that care out, that reads and everything to the company, but we could easily take that back and build a little bit on that infrastructure. So the primary care clinics probably have rooms already available, right? You just need to fit the equipment in there. And space is sometimes a limitation, or many times a limitation, more than money, which was interesting, which is why the TECS equipment was that's why there isn't a slit lamp and everything in there, because there's not enough space. So we just tried to, and you can do a lot of really powerful things now, like combination fundus OCT cameras are out there. And so you could get a lot, just in just one equipment and save that space. And then I think, the billing aspect, coming back to the practicality of, you got to keep the lights on, right? The billing aspect, I think, I do think that you can build this sort of process if you have a video chat. So we do primarily SFT. We call the patients, though, we send them letters for results. We certainly do call them and discuss the findings. And in our Ensign process, all of these patients have disease. So even if it's a store and forward glaucoma visit, we'll be calling Mr. Smith and saying, hey, Mr. Smith, remember you came to our place and had your glaucoma checked? Hey, everything looks really, really good, or hey, we want to change your management. But I don't think you could bill for a phone visit like that outside the VA. So I think you would, put a video visit on there, and then you could bill that. I don't know if that answered your question, but those are my thoughts.
No, it did, because I sort of just wanted to know what you thought some of the logistical challenges were to integrating that a little bit more, because in federally qualified health centers, you already have existing sort of healthcare space in locations oftentimes that are more rural and maybe the only healthcare providers in that area. So to me, it sort
Mhm.
of makes sense to try to look at some of those areas as places to integrate vision care. Um, but I didn't know from sort of your perspective what some of the challenges might be in doing that. So you actually did answered my question perfectly. I
Great.
was trying to think about, you know, what are some of the barriers to doing this? Because to me, it intuitively makes sense to put vision care into some of the services, especially like you mentioned. You know, if somebody comes in for some other healthcare service, if you could also address sort of their vision care issues while they're already there, then you're probably going to lose fewer people who go on to develop advanced glaucoma, and then your options are really limited, and they're going to be visually impaired permanently. So trying to think about from a prevention standpoint, how do we capture some of those people relatively early? I think federally qualified health centers might be really well positioned to do that, but it there's logistical challenges in trying to figure out, you know, what those are and how we should be navigating them. So your insight is actually really helpful.
Yeah, I think that this system would work quite well. And I think that what I would say, just from my experience doing this in the VA, is that for outside VA, the challenge is licensure. But if you're smaller, right, and you're say working within the state, for example, then likely you don't have that licensure issue because the patients are accessing the care within the state and the providers are licensed within that state. So then the issue becomes how do you get paid for it, because you got to, you got to at least be, you know, like you got to keep the lights on, like I said, and you have to figure. And then I think the third thing to think about is what kind of viewing platform are you going to have? Like if you're within a federally qualified health center, I'm certainly you could use the EMR that you already have, but then you need an image storage space. Uh, and this is, I get no money for saying this, FYI. I get no royalties or anything, but like VA DoD is using Forum because Zeiss Forum as our IPACS system. And just to, as an idea for the new National Subspecialty Ophthalmology Network, our hub, we're going to have like a national level forum access. So anybody's eye clinic who has forum will feed into our forum, and that way we can have continuity of care. Because if we're going to treat glaucoma, I need to see all the visual fields you ever had, right? Like, and so it would be kind of a waste of my time and money if I have to repeat all those visual fields all the time via telehealth. And the other thing I should point out here is that we are never saying in any of the stuff that we have done, this goes towards the whole fear of being replaced, right? Um, that you'll never see an in-person doctor again, right? This is not what we are saying. We are simply saying that we can take care of a lot of your medical, your medical eye issues for chronic disease using telehealth, and then maybe once a year, once every 2 years, it depends on what's going on, right? You're going to go get your face-to-face exam. You're going to go get all your peripheral retina looked at. You're going to go get, a gonioscopy, for example, things of that nature. So I just do want to be very, very clear about that. Like, this isn't meant to replace anybody, right? This is meant to just, if you're the retina doctor, you're doing 100 injections a day, like that's kind of helpful if you can send the patient to the telemacula clinic and then say, oh, you don't need to come in today because you're dry right now. And then, of course, I'm really excited about the in-home monitoring technologies and trying to get those integrated into this system as well. And I think the last point I would say on this, because you guys can see I'm very passionate about this sort of stuff, is that the more rural the area, the more I would highly encourage advanced care. So like make your site OCT and visual field capable. Because if you find, because what you'll find, this is what we found, when you do the screening, yes, you're preventing them, but now they have something that, well, they're still rural. Where are they going to go? Right.
And that's something that we'd sort of discussed in the past. You know, if you have these sort of centers that are screening things rurally, you know, how do you then address some of those problems? And I think that you touched on part of it is that there's going to be a workforce issue in the future, and trying to sort of preemptively head off at least some of the problems that we're going to face when the population ages a little bit more, I think is something that's really important. So I try to also wrap my head around, you know, what should the provider distribution look like, and then how do we sort of incentivize individuals to do work in rural communities where they might not otherwise sort of choose to go. And I think that that also is going to require a lot of sort of policy considerations, both probably at the state and at the national level too. But I think some of the things that you're looking at, you know, how uh, I think people often underappreciate the uh, geography as a determinant of health. I think people think about other things is being more influential, but at least in Ohio, where I'm at, if you look at the geographic disparities, that's really huge and something that I think gets overlooked. So I think that you identifying the problem in the rural community and actually quantifying that is actually really helpful to some of the arguments that we're trying to make.
Hi, I just want to make a comment. I'm Chandi Ghosh. I'm the regional administrator at HRSA, the Health Resources and Services Administration, and we're a government agency that funds these FQHCs, these federally qualified health centers.
Awesome.
And your talk resonated so much because it's the same issue actually that health center patients deal with in rural areas. And even though there would be, you know, it would be a great place to send VA patients, you'd have to sort of overlap the map of community health centers and VAs to figure out where they can cover each other, right? Because even rural areas don't have lots of FQHCs, and not all the FQHCs provide all this eye care. Many of them are very advanced. You'll go into an FQHC and it'll blow your mind the eye equipment that they have. Mm-hmm. Others don't offer it at all. So, and the other thing, the payment model really is important because FQHCs traditionally have avoided being involved in, you know, Veterans Choice or TRICARE and all these other insurance for uniform services. And we're trying to work with NAC, which is National Association of Community Health Centers, to incentivize health centers to take these insurances. Because health centers feel there's a lot of red tape, and every time they try to get reimbursement, they don't get it. And so they've sort of washed their hands of the whole thing. So yes, we're going to try to start this process again to get this going. So there could be easy referral back and forth. But the first thing to do, I think, is to put that map of where FQHCs are and where VAs are, and find out who has the capability of taking these patients and giving them complete in-person eye care. But health centers, even alone, are grappling with the same thing. Like, how do we use this hub and spoke model to make sure rural patients get the eye care they need that's over and above telehealth? Telehealth has gotten us very far, but only so far. But when you actually need treatments, how do you get them to these rural areas? So it's the same issue everywhere. So thank you for this talk.
No, so I wanted to ask one is I want to make a couple comments on what you just said. So thank you for, you just kind of sparked my brain for more work in the future. So we are actually doing a mapping project, a geographic mapping project for the VA in my VISN, where we're mapping where the community care providers are, you know, and where are the services within the VA delivered, and then where are the veterans that got diagnosed with certain diseases located. And I think it would be really interesting to add maybe that other element you're talking about, which is federally qualified health centers, or just, you know, other health centers that may be, you know, I think part of the issue right now is that, well, like you said, they won't take VA patients because of, you know, all the things you talked about. And so, but I think just geographically, like better understanding where can these patients go to get care would be helpful. So no, and the second point I wanted to comment about is that I also have thought about this, this concept that you were saying. Well, you got to go beyond telehealth, right? Like I already said right here, if I'm just talking about telehealth, like if you need a procedure, you're done. Like we got to get you somewhere. So we have been piloting within the national VA, and not just in eye care, but in other specialties, what I call mobile deployment, which is essentially that, and we are actually doing this in some of our underserved areas. So for example, if I'm the ophthalmologist. Telehealth is my presence, is my ophthalmology care to these patients when they don't need a procedure or they don't need an in-person exam. But then when I identify that they need a procedure or an exam, I then go to that site periodically. And I rotate. So I have an ophthalmologist. I rotate ophthalmologists that go and do injections, do lasers, do, you know, whatever. Now, then the only thing happens then is the surgical part. But if the federally qualified health centers have an OR, you could be doing surgery there, right? And then you could see them in post-op. And then once, the surgical episode is done or the injections or whatever is done, then they can go back to the telehealth piece when they don't need that procedure anymore. I mean, this is the idea, right? So then what happens is you bring that specialist there, and that specialist is potentially motivated to do that because the telehealth aspect of their job helps, it helps for provider satisfaction and reducing burnout and stuff like this. And so this is a model that the VA has been trying for quite some time, because we've been trying it for 2 or 3 or 4 years, and I mean the ROI is obvious. But you are absolutely correct. Like you can't send a eye doctor, like a retina specialist, to go do injections at one of my TECS sites in like Kalispell, Montana. There's no slit lamp. If there's a problem, we need to do AC tap, whatever. Like it doesn't work. So you have to have like a clinic, because if you're going to do procedures, you need everything you need to take care of the patient safely in case something happens. So I think
Great.
that's one of the challenges.
And let me just add, if you want to find out where community health centers are located around a certain zip code, you go to the website findahealthcenter.hrsa.gov. So find a health center.
Awesome.
.hrsa.gov, and you can put any mile, put a zip code in, and you can put any mileage, 100 miles, and they'll all map out with you.
Okay. Fantastic. I'll do that.
Sure.
I'll let my mapping team know. The other thing that we've kind of been toying with, which is far more complicated. If you think VA is difficult to work with, think if you were trying to work with DoD and VA. But like DoD has quite a few centers, and their doctors are always looking for management of cases to continue their battle readiness things. And so we have been thinking about, can we pair up with DoD for some of our patients? Unfortunately, I think what we are seeing is that the ophthalmology is not usually housed in the rural areas in DoD, so that becomes a bit more challenging. But
right, it tends
we're
to be
looking at
optometry. You're talking about like on military bases, right? DoD
military
hospitals,
bases, right? But some of the military bases are out really like out in the middle of nowhere. And we do have a very DoD has a very good and very strong optometry workforce, but they are all sort of geared towards, like, their time and energy is dedicated to sort of battle readiness, right? So just making sure all the active duty soldiers are like ready for battle, taking care of their eye stuff. And so the retirees and the other beneficiaries, don't are of lower priority because of the mission of DoD. So there's a lot of so they send out a lot of things into the community as well. So I don't know if there's some potential partnership there. We certainly are exploring it on the VA side. There's a lot of red tape. Speaking of red tape, so
one of the things, April, you brought up is sort of you've leveraged the economies of scale, right? Because the VA is a national system, and you go across state boundaries. What if somebody wants to do this more locally, and looking at especially academic health centers? I know you've talked to some of them, including the University of Michigan, who we hope to bring on in one of these spotlights soon. Is there a place for maybe academic centers or health systems to take on this model and develop it? And are they developing in other areas that we can learn from for those of us who are not in a VA system?
I think that the academic centers are very interested in doing something like this. Again, I think the payment model is a pretty significant barrier. Again, if you're in the same system, then you maybe don't have to worry so much about the licensure issue. But the payment model is still remains a significant challenge. So I don't want to underestimate that, because I personally think if people could get paid to do this, that more people would do this, even in private sector. I think where it might be helpful for the so at Emory, for example, our retina team, all of the retina team sees a bunch of patients at Emory at the various main campuses, but then they also all travel once in a while out to the boonies to like take care of the patients. And like if they could leverage a telehealth model like that, that might help. So for example, if if I'm in the satellite office and Emory Retina comes once a week, once a month, but I have something that I know is not procedural. Maybe I can do an e-consult, or I can do the testing. They come in and they do a visit with the patient. Then they don't have to travel. So, sort of things like that, I think might be helpful. And then the academic institutions likely have similar EMRs that will help facilitate this type of work as well.
So on that note, if an academic center or a health system will want to get started, what do you suggest is sort of the first steps to do this? Like where do you begin?
I think I'm a very practical sort of person. So I think that number one, you need to make sure that the partners that you want to work with, your spoke sites, so to speak, actually want to do this. Because if they don't want to do this, there's no point to even try. I mean, or you're going to have to spend a lot of energy getting them on board before you can do it. It's very hard to implement something if nobody wants it there. And so I think you need to I think the first thing to do is get buy-in from both your spoke site and probably the leadership, whoever's going to be at the hub level and whoever's going to be at the spoke site level. And then once you have buy-in, then I think you have to look at the finances. You have to have a business model in place that works. If you were able to get all of that done, then I think the rest of it is actually relatively easy. There's a lot of really good literature published already from the United Kingdom, from Japan, from India about these types of telehealth models, from VA. So I think designing the model and stuff like that is really not as hard as the rest of the pre-work that needs to be done.
That's all in the bottom line. That's the and both
It is.
staffing, monetary.
Yeah, it really is. And I mean, for the VA, again, that's the reason why I think it's a lot easier to do this within the VA. Not that the concept doesn't work, but it's facilitated by being in the VA.
Okay. Dr. Brinks has his hand up. Go ahead.
Hi, April. Hey, thanks for a great presentation. We learned so much from you.
Oh, thank you.
Good lead the way. Hey, quick question or just quick comment on financing. I agree.
Yeah.
We're working on a program like this in Oregon and had to rely on philanthropic funding to quite a degree
Right.
initially. But just for the group, our state Medicaid evidence review committee is made up of primary care physicians. So just like, this really resonates with what you said earlier, April, is these folks really want a program like this where they can hand off the eye care
Yes, they do.
to
Yes.
somebody else. So boy, we presented to those folks 6 months ago. They were so excited. We've had a number of conversations, and I think in 2 months, so hopefully, with some luck, the Oregon Medicaid system will start reimbursing us for a similar program to what you're doing there. So,
That's amazing.
just a vote of confidence and opportunity there, given their receptivity to the idea.
It's awesome, Mitch. Good news.
That's good to know.
This is great. Well, you're talking about the other examples of the world. In fact, we have invited the folks from the International Eye Foundation to come and present. They're both on our Vision 2020 Executive Committee.
Awesome.
John Barrows and then Rahim Rahmatullah. Both are part of this effort that is using primary care vision centers in India to sort of deliver this type of telemedicine-based care and trying to see. So when they get some more results under the belt, they probably present on this, and we can see kind of what happens in another country where you have different challenges and facilitators of this process. So that'll be great. And actually, I've been in contact with one of your colleagues there, April, too, thanks to Chandi, actually. Akshay Abbott
Yes.
is
Dr. Abbott.
He's a great proponent of this, I know, in medical retina, and he may be doing your Ensign program of developing that.
He is. He's going to be one of our retina specialists for all the e-consults and telemacula. We've got a really strong retina team in Vision 23. So
great.
I'm really, they it's really kudos to them, Dr. Abbott, Dr. Keenum, and Dr. Weiss, our retina team that really pushed forward the retina infrastructure. And that's why you see there's many more encounters for retina than there are for glaucoma, because after we did retina, we're like, okay, now we're ready to do glaucoma. And then my charge in the next 6 months is to build out neuro-ophthalmology. And so I'm very excited about that because there's not a lot of, my understanding from my neuro-ophthalmology as subject matter experts and stuff is that there's not a lot out there about neuro-ophthalmology. But I would argue, not that retina and glaucoma are not important, certainly there's a lot of patients with that disease, but that neuro-ophthalmology is even more specialized and even more sparse. So so we're and so one of the fun things from the VAs, speaking about economies of scale, is that now that we have a national sort of tele-ophthalmology hub, we'll be able to collaborate with the other national telehubs that exist in VA, including telestroke, teleneurology, teleradiology, things like that.
That's
So
great. The infrastructure
yeah.
is so key, and that's really important.
Infrastructure is very key. So, I mean, I think it's possible for, I mean, nowadays almost everybody uses some kind of EMR. So I think, you can take that big infrastructure VA is doing, but if you could duplicate that, or you already have that duplicated within your hospital system locally, you can still do this. Um, Again, I think you just have to figure out how you're going to get paid.
Yeah, definitely,
I don't
definitely.
have any answers for you on that. Although what Dr. Brink said, absolutely, a lot of places, like especially Ann Arbor, shout out to my collaborators there, have done this with a lot of different grants,
Mhm.
and then figuring out how to keep it sustainable over time once the grant funding ends.
Definitely, definitely. Thanks, Shandy, for joining. Mitch, did you have another comment, or your hand was still up, so I didn't know? No? Okay. Well, wonderful. So we hope to
No,
have Paul and Newman Casey join
Awesome.
in the future. We hope to
Yeah.
have the folks at IEF join, and of course Dr. Abbott talking about his work in the retina field, to talk more about what you guys are doing in the VA and through subspecialty levels. So this all sounds very exciting, and it may be a good model for us in the United States to deliver healthcare in the private sector as well. John, you came on video. Any comments or questions you have?
No, sorry I'm late. I had it on the calendar wrong. I'll wait for the audio recording, I guess, at the moment. I mean, it's really interesting that there's so many parallels across the world, but the context is totally different and so much more complicated in the US. There's so many layers and to sort through.
Great. And April, you put that Ocular Telehealth, a Practical Guide textbook out there is wonderful. So everybody should look at that as a way to kind of develop this and implement this in their own backyard. So this is
Yeah,
great.
if you're looking for a good resource, shout out to my team that we put this together. It was our COVID project. But I'm hopeful that that the field finds it useful. We tried to make it very practical. There's some chapters in there about billing and coding, some chapters in there about licensure and things like that, and a lot of subspecialist writing, different ways you can integrate telehealth for a specific part of the eye.
Awesome. Awesome. Well, wonderful. Well, thanks all for joining. We may skip the December spotlight since the holidays are coming up, but we'll regroup probably early next year, and we'll come up with a schedule, and we'll talk more about our future meetings. So thanks again, April, for helping us out, and
Thanks for
have a
having
great
me.
weekend. Take
All
care,
right.
guys.
Yeah.
Bye, guys.
Bye-bye.